Thank you, Chair. Just a few questions to begin with around the budget. So the budget through to the end of this financial year is £22 billion. At the time of the report, £4 billion had been spent. Mr. Williams has talked about £1.3 billion further of contracts that's been signed. How much of that £22 billion are you expecting to have spent by the end of the financial year? I don't know if that's for Mr. Williams or Baroness Harding.
Mr. Williams?
Shall I let me pick that up? In terms of the spend year to date, I can update by another month. So we have data to the end of November, and we've now spent 5.7 billion. The forecast is backloaded. The central assessment of the team is that they will spend over 20 billion of that 22, but we continue to develop new use cases, particularly for community testing, use of lateral flow devices and so on. So some of that currently identified forecast underspend is being repurposed within the team. My best estimate is low 20s, maybe very high teens will be probably where we end up.
And so that potentially could be another £15 billion worth in the next 3 months. It's quite an impressive run rate. How does that break down in terms of the spend on testing and the tracing elements? Because at the moment, tracing is a very small portion of the overall budget spend.
So look, of the increase in the budget from 15 to 22 billion, of that 7 billion additional funding, 6.2 billion of that is earmarked for testing. So an additional funding, 6.2 billion of that is earmarked for testing. So testing continues to be the principal driver of cost. But I think the difference here is that a much greater proportion of that uplift is around lateral flow devices, new technologies to support community testing, asymptomatic testing, rather than further material scaling up of laboratory capacity or PCR testing. But obviously, if you're running at 800,000 a day capacity, as Baroness Harding has set out, then the spend on that over a 3-month period in comparison to a period where we have grown from 100 to 200 to 500 to 800, it stacks up pretty quickly. So look, around 90% really of the budget is for testing capacity in one form or another.
Do you in the 207 contracts you referred to earlier, about 15%, sorry, rather, of those had been awarded under the Emergency Regulation 32? What proportion of the £15 billion to be spent do you think will be under those provisions rather than a new award, or preferably a competitive award?
I mean, I think it remains to be seen, and the circumstances may well change. The current central estimate from the commercial team is that in terms of new contract awards to come between now and the end of the financial year, there'll be maybe another 25 to 30 direct awards. We are moving more into tenders, so we've been running a tender for 200 million lateral flow devices, which reached an important decision stage on Friday last week. So with a bit of stability in the programme, we've been able to run competitive processes as we can see contracts coming to an end. So that will be more of a feature. You can see contracts coming to an end. So that will be more of a feature going forward.
What happens with any underspend? Does that stay within test and trace, or go into the wider health budget? I've got a hospital near me that needs to be rebuilt, so if there is an underspend, I'd be interested to have some of that come my way. But
Mr. Weil gets a bingo point for arguing for his local hospital.
The 22 billion will be ring-fenced for test and trace activity, I'm afraid.
I'm glad to hear that, Mr. Williams. A good try, Mr. Weil. Back to you, Mr. Weil.
Thanks very much, Chair. In the spending review, it said that the spending and the allocation will be kept under review, taking into account what it referred to then as a possibility of a vaccine. Obviously, we've now got 3 vaccines licensed, approved, 2 very welcomely being pumped into people's arms across the country. What impact does the vaccine and the plans to have done all of the priority groups by the end of April and the rest of the population by September mean for your planned spend and rollout? Perhaps that's one for you, Baroness Harding.
Maybe if I kick off, and then I might hand over to Mr. Marin for a bit more of the sort of broader context and planning in a sort of vaccine rollout world. From a test and trace perspective, I think it's important that we see testing and tracing sitting alongside the vaccine programme, not an either or. It's very important that we continue that if people have got COVID-like symptoms, that they're coming forward to getting tested, and then us contact tracing any of their recent close contacts. So I would expect that for quite some time we will want to have scale test and trace service, partly to make sure that we are breaking those chains of transmission amongst those of us that have not been vaccinated, partly to make sure that we've got the scale surveillance in place to understand how the vaccine is working, and partly as well as we are learning about the importance of tracking new variants, and to make sure that we've got, as we are learning about the importance of tracking new variants, and to make sure that we've got that very early warning system in place. It's because of the scale, test and trace, and the integration between test and trace and Public Health England that we're able to do so much genomic sequencing. The UK has done over 50% of all the whole genome sequences of COVID in the world, and we're looking to continually expand that, and that is an end-to-end integrated process as we hunt down those new variants. So I would expect there to be scale operations going into the forthcoming year, and we will have to work through how to adapt as the virus itself adapts. I don't know, Mr. Marin, if you want to talk more about the broader position.
Thank you, Baroness Harding. So I think the first thing to say is obviously the things we still don't know about the vaccine. Very encouraging results out of its clinical trials. We continue to use our surveillance to work out the key question of whether the vaccine actually stops people spreading the disease. So that obviously will make a massive difference to what we can then do in the way of both test and tracing and other NPIs. So that work's ongoing with a very effective surveillance programme in place now to give us those results as early as possible. As Baroness Harding says, if we are able both to reduce the numbers of people with serious illness and indeed if it stops transmission, as cases fall, it may be possible to switch testing from real focus on symptomatic patients to doing much more asymptomatic testing. And that work, I think, will be important. And if we look further ahead, obviously, we're thinking about establishing the new National Institute of Health Protection and making sure that it takes on the level of testing and tracing capability that will be needed on a longer term to make sure that we remain resilient both through this wave of this pandemic, any subsequent waves, and indeed are ready to deal with further epidemics and other threats to health that might through this wave of this pandemic, any subsequent waves, and indeed are ready to deal with further epidemics and other threats to health that might arise in the future.
Maybe I'd just also finally add that the economic and human cost of the restrictions that we're all living under now is obviously so much greater than maintaining a test and trace service that is reducing our substantially. So I would expect us to want to continue to do that and be able to release other restrictions earlier. So, Chris?
Yeah, the only thing I was going to add, because I think it relates to Mr. Holbert's questions right at the beginning, actually. So obviously there are lots of decisions still to be taken, but I would be very surprised if one of our conclusions was not that we want to have a much bigger standing diagnostics industry, both in the public and the private sector going forward beyond the pandemic. So I think it goes wider than just the current test and trace position. And as Mr. Maron said, that will be a key issue for the new NIHP.
Thank you. The report refers to the government working to reach the daily target of 800,000 tests by the end of January capacity, and looking at the excellent COVID statistics gov.uk website. Clearly, you've already met that target. Is the ambition to go higher than 800,000? Is there a new target beyond that, or is this the capacity you think we need?
I think that we will look to blend our different laboratories rather than necessarily look to continually expand. So, for example, we've announced the opening of a mega lab in Leamington Spa using a new technology called endpoint PCR, which is a PCR test done in much greater scale, and therefore that brings the cost per test down substantially. So I think you'll see new investments, but in order to be able to build a more efficient scale operation rather than necessarily to continue to expand. Okay. That is all on the PCR testing capacity. Yeah. I would expect us to see continued expansion of asymptomatic testing using lateral flow testing at its core.
Mr. Wild.
Yeah, and just you talked earlier about the legacy and about the diagnostics industry. Of the Lighthouse labs are now up and running, are those NHS Test and Trace owned and operated? Are they privately owned? How will you ensure that capacity is there going forward?
There's no one single model. The Lighthouse labs, although we talk about them as a group, have been created and established in different ways, from entirely private Randox in Northern Ireland to partnerships with NHS trusts in Newcastle Ways, from entirely private Randox in Northern Ireland to partnerships with NHS trusts in Newcastle and Royal Berks, and partnerships with universities, Glasgow, for example. So there isn't a single model, and part of the work that we are starting to do now as we look towards the National Institute for Health Protection is to work through how that model should evolve in a post-COVID world. So too early to give you a definitive answer, but it's very much on our minds to start working through now.
Mr. Wild.
So is there, Mr. Williams, do you have a sense of cost? I mean, if these sites are mothballed at some point in the future, and then we need to have the capacity there ready to switch on, has the department done any work on the costs of having that capacity sat there waiting?
That's one of the things I think we will need to do over probably the course of this year, to look at the balance between a lower level throughput to keep facilities ticking over, or whether we put some into extended readiness, to use the military metaphor. But also, I mean, just picking up on Mr. Smith's line of questioning earlier, the sort of endpoint PCR tests, we ought to be able to deliver for £8 to £10 a test. So thinking about the balance of at scale testing their capacity in the network of Lighthouse labs, and as Mr. Holden was asking earlier, lab capacity within the NHS in Pillar 1 is really all in the mix for decisions this year, I think.
Okay. In the report, it refers to a pilot in September about using sample pooling as a way to speed up the testing process. Is that something that has been rolled out since the report was written?
Unfortunately, sample pooling as a technique is only really effective when you have relatively low prevalence, because obviously it relies on there being a large number of pools where there will be no positive, and therefore you don't need to test each individual. So as we stand currently, it's not appropriate to use, but it is a technology that has been used successfully in parts of the network, and I'm sure it's something that we will come back to as infection rates come down again.
Okay, if I could come on to just ask a few questions about the mass testing programme. How accurate are the lateral flow tests? I mean, there's reports that they range from 50% accuracy up to some claiming 99%. What is your view? What are the, I think there are 3 primary tests that we use, and what's the accuracy of each?
Yes, well, I'd refer you to the document that Public Health England, Porton Down and Oxford University published in the autumn, setting out the evidence from their validation of the 3 tests. So as clearly this is important that it's the sort of scientific evidence. But in layman's terms, the lateral flow tests that have passed the assessment of the team in Porton Down are over 99% specific, but lower sensitivity. What that means, again, in more layman's terms, is that you're highly likely, if the test says that you are positive, you are very highly likely, over 99%, to be likely that you are indeed COVID positive. If you get a negative result, you are circa, and it's a slightly different result for each of the 3 tests that have been successfully through the process, circa 78% likely to be negative. And as we were describing earlier, it means these are tests that are a very useful addition to our overall testing toolkit. If you have symptoms, we would want you to come forward for a PCR test. But if you are taking to our overall testing toolkit, if you have symptoms, we would want you to come forward for a PCR test. But if you are taking, as our colleagues in the NHS are now, twice a week, or all our colleagues in social care twice a week, taking a lateral flow test twice a week as part of a regular testing regime, it finds people who would not otherwise know that they had the disease.
Mr. Wild.
How many lateral flow tests do we have in warehouses and currently available?
We have a very large number of lateral flow tests. Sorry, I don't have the precise number to hand, in the hundreds of millions rather than the millions. So we have very large stock in order to be able to deploy them across all key workers and people who have to leave home now, but also into health, social care, schools and other sectors. So as a country, we're in a very strong position to be able to use this new technology.
There's no reason sorry.
Mr. Wild?
If it helps, from the procurement over the summer with the 3 tests that you've already mentioned, Mr. Wild, we bought 384 million tests. We have just made a direct award for a further 239 million tests, which will be delivered from now through to mid-February, in advance of delivery through a tender process of up to a further 200 million tests from mid-February through into early March.
Great. So to come back to the point Mr. Smith made earlier, there's no reason why food processing plants or others shouldn't have access to lateral flow tests.
No, that's absolutely right. We're working with many of the sector.
Right, so they can get hold of them. Thank you. Mr. Wild?
Yeah, is the concept of testing an entire region in order, as we lift the restrictions, to come down the tiers, something that's being considered? Lift the restrictions to come down the tiers, something that's being considered?
Well, we're looking at a number of different ways of making use of this technology, and obviously piloted exactly what you described with the Liverpool City region before Christmas. So it's definitely one of the suites of options that this new technology and the growing sort of distribution network through community testing and employers gives us.
And it's coming to the end of my questions here. In terms of the tracing strategy over the next 6 months, particularly with the mass testing and also looking at increased local authority and public health director involvement, what does that look like over the next 6 months? What changes might we see?
I think
local authority and public health director involvement, what does that look like over the next 6 months? What changes might we see?
I think that 2 big changes. The first one is making more and more use of what we call extended contact tracing. So looking backwards to identify for each positive case where that individual was infected in order to be able to stamp out clusters even faster. That's a technique that is most effective when you're at much lower infection rates and requires much more collaboration and ownership locally with local health protection teams and local authorities doing that sort of detective work. That's the first thing, and we're working with a number of local directors of public health on piloting sort of improved tools to help them do that as we speak. The other big theme for contact tracing going forward will be genomics. So as you see us doing now, as the virus mutates and new variants are identified, being able to then very rapidly identify contacts and sequence whole viral genomes in order to understand where you're seeing new variants take hold that might have potential risks for us as a country, and then to be able to take very swift action. So those are the two big themes I'd point to for contact tracing going forward.
Mr. Wild?
Okay, final question for me is around, in terms of the schools, teachers in my constituency raised concerns about people taking daily tests rather than if they're in close contact rather than self-isolating.